And welcome to my portion of the Eyes on Eye Care 2022 meeting. I'm really excited to give you this talk here. I have refractive cataract surgery, novel trends and techniques, which is a pretty big topic to tackle, but I think it's going to be a fun one. I think we have some good material to go over today, so I'm pretty excited. Let's go ahead and get started. So in terms of financial disclosures, I have no direct conflicts here. I do have two other companies I'm involved with, and one that receives royalty payments from Volk Optical, but none of these are discussed in the talk, so I think we should be good to go. So I'll give you a little outline for today. Again, this is a pretty meaty topic here and a lot of material to go over, but I will try to break down how we're going to do this talk here today. So I figured it would make sense to break this into pre-operative topics, operative trends, and then post-operative trends to try to sort out all of the different areas we wanted to go through today. In our pre-operative trends, we'll be talking about lens calculations and some basics there and some newer calculations to think about. We'll be talking about the concept of using Lipiflow pre-operatively, which again is a newer topic to think about. Operative trends, we broke this down into techniques and devices. So for techniques, we're going to be looking at the heads-up 3D visualization systems. We'll be looking at femtosecond laser-assisted cataract surgery, which is not really new to anyone, but I think worth reviewing. Intraoperative barometry, or the Aura system. Another good one here, I think, immediate bilateral sequential cataract surgery. And intracameral antibiotics. Again, not another new topic, but I think an important one to go over. Then we have the power wash and Singer sweep, which is actually just a video and technique that was sent to me. This one's kind of just for fun, but I think interesting. In terms of devices, we'll be looking at the MyLoop. We'll be talking about some trendy intraocular lenses. That's going to be a brief conversation as well, because I know there's other talks on the intraocular lenses. And then some new Elcon tips and handpieces to look at. Those will be our devices. Post-operatively, we'll be looking at lens issues and problems, and everyone's favorite and or most dreaded, fixing the dropped or dislocated intraocular lens. So with that being said, that's our review, and we are going to dive right in here. Preoperative trends. So we're talking about lens calculation. So, for cataract surgery, arguably, perhaps the most important part of the surgery comes preoperatively with getting good measurements and using the correct formula. Ultimately, we're judged on the refractive outcomes. So finding the right formula is just absolutely crucial, as we all know. You can do a flawless surgery, challenging dense white cataract in a patient who's had LASIK, and you'll land 2 diopters hyperopic, and they're going to be miserable. And you got through this horrific surgery, thought it was perfect, but they're unhappy because the formula you chose didn't work out well for you. So of course, there's a lot of importance here with our calculations. So again, we'll start with a little review of our most commonly seen formulas. We'll go over our 3rd and 4th generation, talk about some newer ones, and some special cases and considerations to think about as well. So to start here, our Vergence formulas. These are going to be our 3rd generation and 4th generation formulas. So 3rd generation, we all know the SRKT, the Hoffer Q, the Holiday 1. SRKT is probably one of the most popular, maybe not as much anymore, but that was our go-to for a lot of us. And amongst the 3rd generation, the SRKT is really best for eyes over 26 millimeters. The medium range, 23 to 25 millimeter eyes, most are relatively equivalent. Still popular, the SRKT. I was actually using that up until a couple years ago when we got our new IOL master. But these newer generation formulas are really gaining a lot of traction. So we'll touch on those as well. This would be our 4th generation. So we have our Hagus Holiday 2, our Barrett Universal 2. These include more variables in their calculation, which is part of what makes them more accurate. The Barrett is really being accepted as probably the most accurate amongst these right now. It tends to hold up best in these studies that we have. The Barrett incorporates a principal plane of the intraocular lens, And when we look at these studies, it tends to hold up really well at a wide range of axial lengths and anterior chamber depths. So it does really good. The study I think Mellis in 2018 in ophthalmology showed that Barrett had the smallest percent of eyes outside the one diopter prediction error, and it held up best against the other third and fourth generation formula. So that is our main bread and butter formula right now, that Barrett to universal. Next generation, this is kind of important. And I think this is part of the novel trends part of this. So we'll start with the Hill RBF, and this one uses AI and regression analysis. So this is based on empiric data. The problem being is some eye characteristics can fall out of the scope, and the eye roll prediction can actually be a little bit less accurate. But there is the new Hill RBF 2.0, which does continue to improve, and this is one to watch for sure. Kane, you might have heard of the Kane formula. This one also uses AI and theoretical optics. Some pretty large studies. There was one with 11,000 patients that showed it was actually more accurate at all axial lengths and had the smallest absolute error in long eyes over 26 millimeters. I've been thinking about this one. I've been plugging this into the online calculator a couple times. It seems to match up pretty well with the Barrett Universal 2 and others, but it is one to run if you're maybe on the fence with two powers. It is something to look at and to think about. The last one in terms of next generation, another one you might have heard of, is the Lattice, or now it's the Lattice 2.0. This one is dubbed the quote unquote super formula, which may be a little bit generous. And what this does essentially is it helps select the best formula based on your axial length and keratometry for each eye. And it uses same thing, deep learning and AI. And I think there's a lot of potential for this to keep improving. The more data that gets plugged in, the better this formula gets. And I think it's on eyewellcalc.com, not really in your standard biometry machines, but it is something again to look out for. This is a work in progress, but I think a lot of promise here. And also for here, I guess to mention some special cases. So ectasias, keratoconus. None of these are really great. There was a good study, this was Wang from 2020, showed that Barrett did the best for mild to moderate ectasia, which I can't define that clearly, but in the severe cases, they were all pretty much poor performers, as you can imagine. So maybe some room for improvement there in the future. Post-refractive, I tend to lean towards the Barrett Truquet. I know there was a 2016 study that looked at a few of these, and it showed that it had the smallest error compared to the Hagesel Maloney Masket. The other big one is the Hagesel that I think a lot of us lean on, and especially myself and my partners. But the Barrett Truquet, actually, the data shows it might be a little bit better. So this, I think the most important part, of course, is just having that conversation with your patients, though, to know that there's going to be some challenges and unpredictability there. All right, let's take a look at the next topic here. So our next and last preoperative trend, we'll talk about Lipiflow a little bit here. So the basic overview is this is for those that don't know, it's a 12-minute in-office treatment where you place a little activator which cups the surface of the eye, surrounds the lids, and it heats and compresses the lids for 12 minutes. So most practices that have this just use this as another tool in their dry eye toolkit, which is fair. The benefit for dry eye treatment is that there's actually reasonably good data that in the properly selected patient, it's pretty helpful. It can make a difference. They were showing, there was a study we quoted there, it showed 86% of people showed improved MGD scores, 50% had reduced mean dry eye scores, and it's been around for a while. It's been around for 10 plus years. But again, where this fits in the talk here is the trend for using this in pre-op for cataract surgery. So, from this standpoint, we all have our ocular surface disease patients in our cataract evaluation, some worse than others, of course, but it's pretty important to be treating these preoperatively, of course, and it's fine to use your standard treatments, tears, hot compresses, Restasis, plugs, lid hygiene, etc. But it is just super important to treat them, of course. And the main reason being, of course, is this going to affect your keratometry and your measurements. So the Lipiflow fitting in here this is just another option. It's been popping up in literature as helpful. And I think the idea is that in a premium practice where the Ks are so important for your multifocal or your EDOF or torics, really optimizing the surface can be helpful. there was a pilot study looking at Lipiflow preoperatively and showed 40% of the patients had a change in their astigmatism when they had their Lipiflow done in the biometry before and afterwards. So it's just something to be thinking about. I think they were doing it about 3 weeks before the surgery in these studies. So I have a little personal experience with this. We just got this device a couple months ago. And in all honesty, it's been a fun tool to have. It's been working really well. I'm pretty selective in who I use this for. It's not really first line for me, but again, in the patient that's on multiple lines of treatment, it's just another device to have. I think it's going to take a little bit more time to play out, but it's cool to think about optimizing your patients with another tool. Cost being the big consideration here is I think an important one, but certainly it's something to consider. So we'll move into our operative trends and we'll start with techniques. The big one here we're going to talk about is the heads-up display. So what is it? Heads-up surgery is performed not looking through the scope, which is a rather interesting and novel concept, but rather you're viewing a panel display from a 3D camera. So this is derived from the heads-up display used in aircraft flight decks. And this was first reported by Weinstock in 2010 at an ARCRS case meeting. And he had really good outcomes. This was when it was True Vision. I think they were maybe more recently acquired, but that's sort of where it comes from. So the Ingenuity is the system in play right now, and how this works. Images are captured with a 3D camera, and then the images are sent to a remote high definition monitor. The surgeon and any observers can use these circularly polarized 3D glasses to view the monitor to get that 3D picture and image. So the benefits are relatively straightforward and pretty clear. So ergonomics is a big one. 62% of ophthalmologists report neck, upper body, lower back problems, and it's just endemic. And so the idea here is to, as you can see in that picture, you can have a nice posture there and can be really comfortable. In terms of surgical view benefits, per Alcon, who is the owner of Ingenuity now, that you can get an extended depth of field up to 5 times. You can increase your magnification more. The resolution should be improved. And you can also adjust pretty nicely, like color, temperature, and you would actually need a little bit less light. And so the concept of reducing phototoxicity is in play as well. And the last thing I would say would be teaching. Students, residents, staff, presentations of surgical videos, meetings are going to be better. And if you can see them in 3D, it would be pretty impressive to see. So there is a decent upside here. The data, really what we have is some data from that same Dr. Weinstock, who published a paper in 2019 with 2,300 eyes he looked at, and he just showed essentially equivalent surgical time and equivalent complication rates, I think, which is kind of all we could really ask for right now. I think it's something we'll be seeing in magazines and ads and meetings, but it is something to pay attention to. It's a pretty novel idea. The second part of this will be head-mounted systems. So this will be more like an Oculus headset, and this differs in that each eye actually gets a different image, and it's apparently pretty high resolution as well. To me, it seems maybe a little bit more challenging because I like to look down at the patient. I'm usually adjusting their head, the speculum, things like that. So there's a little bit of some inherent challenge in my mind with this one because you can't see you actually have this headset on your eyes. But again, these two are ones to look out for as well. All right, so we're going to touch on Femtosecond and Femtosecond laser-assisted cataract surgery. So again, this is nothing new. This is nothing that earth-shattering here that we're going to talk about. But this is a pretty meaty part of cataract surgery. So the basics of the femto laser assisted surgery is, you can create a wound, you can do AKs, capsulotomy, nuclear fragmentation. This has been around since 2010, as you probably know, for cataract surgery. And it was initially thought to really revolutionize surgery. Since then, I think it's more nuanced in terms of the benefits for sure. I have this conversation almost probably daily with patients about are you doing the laser surgery or are you doing the manual surgery? And we actually don't do femto in our office. So it's an added couple minutes of conversation with patients probably almost daily talking about the femtosecond versus traditional cataract surgery. So the benefits, like we talked about, you can have a quote unquote perfect capsulotomy for good lens centration, especially if you have a premium multifocal lens, for example. It's nice to have a perfectly centered and perfectly round capsulotomy, of course. You can get really precise AK incisions, and you can get some reduction in your phaco time. And so theoretically less endothelial cell loss and less energy overall. The drawbacks here, I think, are pretty clear. The cost of the laser to the surgeon, cost that gets passed along to the patient. I mean, those are two big ones to think about. There are actually, of course, some capsular complications to think about as well. And there's a learning curve too. You know, I think a lot of us have really optimized so beautifully our quick cataract surgeries. To introduce this there certainly is a learning curve to becoming proficient here. I think among special circumstances, this is kind of where some of the nuance comes. So thinking about femto for your Fuchs dystrophy patient, ultradense nuclei, I think there's a little bit more to be said in these cases. So there was actually just a recent study that came out in August of this year that showed actually wasn't a difference in vision outcomes with mild or moderate Fuchs. That was in Clinical Ophthalmology by Koo, and that was in August of 2021. But the ultradense nuclei, I think there is perhaps less phacoenergy, less stress on the zonules. I think there is certainly an argument that can be made for specific cases to fit in femto. Not to say that it's a bad thing or you shouldn't do it, but in terms of convincing data, I just think it's maybe not quite as big of a bang as we thought it would make initially, put it that way. So let's take a look here. Actually, we have a nice video. This video is borrowed from Dr. Devgan, and this is one of the complications that we can see with our femto laser. So I will go ahead and give this a play here.
Femtosecond laser capsulotomy. And you can see there's that danger zone where it didn't go through. Now we've done the rhexis with our femtosecond laser. We're going to make the incisions with our traditional blades and diamond keratome. So we've made one paracentesis. We're going to put trypan blue dye in the eye. It'll help us visualize this a little bit better. And then let's dilute the trypan blue dye with our anesthetic solution, which is lidocaine with epinephrine mixed with bounce salt solution. And now we can see quite clearly that there's still a lot of adhesions of the capsulotomy. It's not a free-floating capsule cutout. So now what should we do? I actually want to make a second paracentesis. And the reason is I want to put viscoelastic in the eye, but I don't want to put viscoelastic underneath that femto-made capsule flap. So there's the second paracentesis. Now I can inject our viscoelastic and push that back down, and we'll get a better view of where we still have capsular adhesion. So there we can see it's those few clock hours. Looks like it's perforated, so it's partial but not complete. We use our diamond keratome to make our incision on the steep axis for the patient. There's a nice incision there. And now here's the technique using the Capsulorhexis forceps. We're going to use the same technique as we do for Capsulorhexis. So we'll grab the tissue here and we'll use a rotational force to separate those pieces. And now we have a complete separation. We still have to be very careful in that one area because it could be weak. Now this is a soft lens on a young patient. We're just going to use the IA probe to remove the entirety of the cataract. So we don't actually need to use the phaco probe. There is no density here. This patient, again, is quite young. You can tell by looking at the eyelashes and the periocular skin that this patient is very youthful. So removing all of the lens material with just the IA probe. Because this patient was in a trauma, you got to be very careful to ensure that there's not a break in the capsule, such as a posterior break. And in this case, everything looks fine. So just take some time here, removing all of the lens material, then we can finish up the case. So bottom line for today is, be careful these intumescent white cataracts. Sometimes the femtosecond laser won't do a complete capsulotomy, And that may be because of lens milk that is being expressed, blocking the laser beam.
That was a good video from Dr. Devgan, borrowed with his permission, and it shows that Femto does give you a great capsulotomy, except for the times where it doesn't. All right, so let's move on to the next topic here. All right, so this is another big one here. So intraoperative barometry. This would be like our Aura system, for example. So the basic principle here, again, this is not a new one for most. Basic principle is we have intraoperative wavefront barometry. It's a tool to gain extra data in deciding on your intraocular lens and position. The surgeon can take aphakic, pseudophakic measurements to aid in the lens selection and position for toric lenses. I can't really give you details on the root mean square and Zernike's polynomial, but we can trust that it works. So the roles in modern cataract surgery are, so for a monofocal lens, the studies are somewhat inconclusive on the superiority of Aura versus standard biometry. For an uncomplicated eye with a monofocal lens, I think most feel that the Aura is maybe not necessary per se. But when we get into our other special situations, premium lenses, post-refractive, I think that's where maybe where more of the value comes here in terms of being added. So premium lenses, your torics. Obviously, there's a lot of precision required for a toric lens, and you can see an obvious benefit here. And I think there's certainly data to support this as well. So there was a study from Hatch in 2015 that showed you're 2.5 times more likely to have less than half a diopter of residual astigmatism with Aura versus standard biometry. And I think I can buy this, definitely. So additionally, you can also get some precision after your placement because you get pseudophakic measurements too once the implant is in. So certainly I think from the premium lens standpoint, the Aura, there certainly is some value that you can add there. Post-refractive, this I think is also another topic to consider with the Aura here. So post-LASIK, there's some decent data showing, the mean prediction error is pretty small. There's 0.35 diopters, and there's 67% within half a diopter, 94% within 1 diopter. And so I think there is decent, again, supporting data that in a post-LASIK eye, the Aura can actually give you some good measurements as well. Post-RK eyes, there was a study, Corrado, in 2019 in Journal of Refractive Surgery, and showed no difference in 52 RK eyes they looked at comparing TrueK, Aura. And so I think in an RKI, as we all know, there's a little bit of a crapshoot that happens there, regardless of if you use Aura or not. But again, those are some benefits there, certainly. Now, in terms of limitations, there's, I think, a learning curve here. And, there's nuances that's described in the literature. And even talking with my partners that use this more regularly, things like achieving the proper lid speculum placement, your IOP, your right stromal hydration, et cetera. I think those things are important to make sure that your Aura really gives you the proper measurements. There's of course a financial cost to the patient, I think at the end of the day, the way to look at this is it's simply just one more measurement here. And I think as it's described again with my partners, it can really just act as a nudge. If you're on the fence for a toric lens or a power one way or the other, it can kind of provide a bit of a nudge there. I think maybe the jury's still out a little bit here, but an important one to talk about and think about. So this is, I think, a really good and cool topic to talk about. So immediate bilateral sequential surgery. This topic is another one that's definitely trending. It's gaining a lot of traction lately. It was something that I guess in training and prior, it seemed like an absolute no-no, but I think this one deserves more discussion. So the benefits here, I think, are relatively straightforward to consider. So you have one anesthesia event, which can actually be pretty important for some patients and safer. We can talk about reduced hospital cost. Dr. Ahmed in Ophthalmology Editorial showed a 32.4% reduction in hospital cost by doing this. Vision recovery. So also having a quicker return to work, a quicker return to functioning, especially you could think of in those extreme eyes, minus 18 patient, just imagine how difficult that can be. Just having one eye in those 2 weeks or 3 weeks being in purgatory there can be a challenge for sure. And to not have to deal with those weeks of misery can be pretty helpful. So those are the benefits, and the drawbacks I think are something that we all have on the top of our minds. Endophthalmitis, that would be bilateral endophthalmitis. That would be like worst case scenario. But luckily, the rates are really low. In fact, there was a JCRS paper in 2011 looking at 95,000 cases and showed no bilateral endophthalmitis cases. I think the overall rates were really low when looking at the literature, like 1 in 6,000, and it was even lower for intracamerals. It was like 1 in 14,000 to get one endophthalmitis. So there's a funny letter that was published in Eye in 2010 that said there was data that looked at the likelihood of dying in a car accident to your post-op appointment was maybe higher than getting bilateral endophthalmitis, which I thought was pretty interesting. So that would, of course, be the one big drawback. Refractive error. You can't really use what you've learned in the first eye to help you hone in on the second eye. Now, one could argue maybe there are other things that can help circumvent that, like a light adjustable lens, for example, might, again, get around the need for that, but certainly that is one to consider. And then reimbursement would be another one. Only 50% of the second surgery in most cases is covered. So there is a reimbursement issue there. So who's a good candidate? Who is someone to maybe give some consideration to this if this is on your mind? If general anesthesia is required, obviously that can be a big deal. If a patient's coming from hundreds of miles away, that might be another one. If you're in a bit more of a rural setting and someone's coming from 350 miles away, that might be something to think about. Very significant comorbidities, Alzheimer's, Parkinson's, wheelchair bound, it's just really going to be difficult for surgery. And then probably you also don't want to have a really high risk surgery. So someone that has zonular issues, bad diabetic that might get CME, pseudoexfoliation, those probably aren't the patients that you want to try and do 2 eyes in one setting. In terms of implementation, so some general recommendations, things to think about. Having a special consent form, that's been mentioned a couple times, I think is a pretty reasonably good idea to talk about the added risk and have the patient sign off on those ideas. Certainly always having a separate setup, instruments, re-sterilizing all new materials, that is going to be absolutely crucial to, again, help reduce your risk of infection and things of that nature. And then thinking about the light adjustable lens in the future. That's one we'll kind of touch on later that I think is a good one. And this, again, just overall, I think is becoming a little bit more popular, and part of the reason I wanted to talk about this. There was Dr. Elizabeth Yu. She was cited saying she does anywhere from 1 to 5% of her cases in this manner. So I think that is, again, something else to keep in mind here. So interesting topic and one to think about, certainly. All right, so intracameral antibiotics. Again, this is not a new one for most people, but I think there is some meat here that's worth talking about, and maybe even just getting a refresher on, if anything. So, of course, we have some really big data to support the use of intracameral antibiotics. The trend took off after this. I think probably after that 2007 ES CRS study showing a 5 times decrease in post-operative endophthalmitis using the intracameral cefuroxime in that study. And the studies just continue to keep coming out with strong support. The one in 2017 looked at 617,000 cases, and there was a 3.5 times reduction. They were using intracameral moxifloxacin, I think, for that one. So the interesting thing, again, despite all this really increasingly good evidence and high quality evidence, it's not quite a consensus there is no quite consensus for a regimen, and still actually not universally adopted, including my own ambulatory surgery center, interestingly enough. So something to think about, using the intracamerals as an adjuvant or just standalone. There was a 2017 Cochrane review that looked at this exact topic, and I think it showed there was a similar efficacy of intracameral versus intracameral plus the topical. So basically equivalent, so it could be a standalone. Other routes to think about, and this would be more like intravitreal. So these usually are combining the steroid and antibiotic, or these combos like the Trimoxy, Vanc, Dexmoxy, Ketorolac, etc. That was introduced in 2005, I think Gillis and Koch. Longer lasting, of course, but also has its own sets of issues there. So what are the pitfalls? And why is this not completely universal? What are some of the barriers? So complications, I think, would be one of them potentially. TAS, cornea endothelial toxicity. Actually, the picture that we're looking at here, this is our vancomycin-associated hemorrhagic occlusive retinal vasculitis, our most dreaded, one of the more dreaded things. But this is with vancomycin, of course, and that's obviously not as commonly used anymore. But you don't want your patient's retina looking like this one here in this picture afterwards. Logistics, certainly cost to your ambulatory surgery center, and then getting your drugs compounded and mixed properly and having this available at your surgery center would be the other challenge. So logistics can be another big one for why this might not be completely universal. So this last one here, we will take a look at. This was sent to me from a colleague, actually, and I just thought this one was kind of fun. It's a video called the Power Wash and Singer Sweep. And this essentially is a short little video, and it's just showing a technique of polishing the capsule. So I will get this playing here, and we'll take a look. There's no audio on this one, so I'll just let you watch this. It's about 2 minutes here. So this is going to be after the lens and cortex is removed. Instead of using your traditional polisher here, essentially the surgeon uses a cannula with BSS to quote unquote power wash the capsule, which I just thought was interesting. And so you'll kind of see him go in through his incisions here and literally actually power wash the different portions of the capsule, and tries to go into each different quadrant and just wash away any residual lens cells left over. I guess he really doesn't want any, not even a single lens cell left over afterwards, but you can see how clear the capsule gets here. I've had my own series of issues with polishing capsules. I've had 2 burrs on 2 different types of capsule polishers, and after a seemingly perfect surgery have ripped that posterior capsule when doing a polish, which is not ideal, but certainly can happen. So this one seems a little bit safer, a little bit more time intensive and cumbersome, and you can see how many times he's going in here, but I do think it's a pretty novel idea and concept. So I'll let you see here. I think he's just gonna put in his viscoelastic and his lens in next, but yeah, it clearly produces a pretty nice looking capsule in the end here. All right, so now in our operative trends, we're going to touch on devices. So this one is the MyLoop. Little background here. So the technique, I believe, was first described in '95, actually, Dr. Keener. And then it was further described in greater detail in 2009. That was Bhattacharya, I think. And then I'll actually show you guys a video. This was in 2009 by Dr. Yunusov from Kyrgyzstan. And this was shared to me by Dr. Uday Devgan, who told me and actually shared an original video with me that I'll be showing you, and gave me a little bit of a background on the MyLoop when I was asking him about any cool videos he had for this one. So we'll take a look at that in just a minute here. So the concept is pretty simple. We're using a snare-like retractable device to disassemble the lens, a dense nuclei, a dense nucleus with less phacoenergy. So this is a nitinol retractable filament, and this was FDA registered in 2017. But as we said, this has actually been around, this concept has been around for many years before that. So the benefits here are, relatively clear. So reduced phacoenergy. There was a BJO study showing a 53% reduction in phacoenergy in these 3 to 4 plus NS cataracts, which I think is relatively impressive. I can believe this. So I've used this for a couple dozen or so cases, and I think it certainly does help reduce phaco energy. I'm not entirely sure in comparing an efficient chop or a stop and chop technique, but certainly if you're still divide and conquering for a brunescent lens, there is a lot less energy that's going to be expended here. The other one would be less zonular stress. I think perhaps this is true. I kind of found in very difficult cases, even simply placing the loop stressed the zonules, it seemed like, in my experience here. And I actually even also had a case with a difficult view through the cornea on a really, really dense lens. And I actually deployed this over the capsule and rotated this, causing some massive stress on the zonules and discomfort to the patient, which we figured out pretty quickly, but not entirely stress-free on those zonules, potentially when you're in your learning curve as well, especially. So faster surgery. I think perhaps after you get over that hump, after that learning curve and you get very efficient, sure. But I do think there is also, again, a fair amount of nuance with this one in terms of placement, using your second instrument to help keep the lens from rotating on you. And it's kind of hard to want to learn on the most difficult cases where it's really the most useful, but it's certainly a tool to think about that's out there. And might be something to consider for really brunescent lenses. Certainly if you're still dividing and conquering, it might be helpful there. So as I said, in the couple dozen cases, I thought it was reasonably useful and there was some utility here. But again, with a Centurion machine, proper settings, it doesn't seem like there's a lens that you just can't get through anymore. So it was fun, but I stopped using it after a couple boxes and my trial devices ran out. But I do think it's, again, worth looking at. I wouldn't call it a game changer, but again, helpful. So pitfalls, I think, again, the big one, poor placement, causing more drama to zonules. There certainly is some challenges here. So I'm going to share this video coming up next from Dr. Devgan that he shared with me, showing a MyLoop in a nice brunescent lens to give you a visual here. So let's take a look at that next.
Lens snare technique for a dense nucleus. Guest surgeons Dr. Malik Yunusov from Bishkek, Kyrgyzstan. So here's the cataract, 2 paracenteses being made with a diamond, and now diamond keratome for the main incision. I'm going to put some trypan blue dye under air to stain the anterior lens capsule. Here's the viscoelastic. Now for the Capsulorhexis, for a very dense brunescent cataract like this, make a generous Capsulorhexis, at least 5 to 5.5 millimeters in diameter. I'll even give you permission to go bigger. But 5.5 is my goal on these. Hydrodissection is being carried out now with a blunt cannula to free that nucleus. Very important to free the nucleus and separate it from the posterior capsule. Now, with viscoelastic, here comes the lens snare. It's a loop. It goes around to the back surface, and then it can be pulled, and this metal wire will now split or bifurcate that nucleus. Now, through the side port, a chopper is being used just to help give stability to the nucleus so it doesn't rotate, doesn't come towards the corneal endothelium. And now, rotating at 90 degrees and applying it yet again, this time the nucleus can be separated into smaller pieces. So here it is being rotated, and then we can break each of those heminuclear pieces into quadrants. Each quadrant can then be removed. And now sub-chopping the quadrant of the smaller pieces, this snare is a nice way of breaking up a very dense or thick posterior plate. And it can be used in a variety of eyes. It's primarily meant for dense cataracts. Certainly you could use a chopper instead, or a reverse chopper going behind the nucleus like I do with the phaco chopper in my dense cataracts. I do not typically use this lens snare, so I thought it was important to show a video from a surgeon who does have experience with it. So here, taking down the last bit of it. Now there's a second nuclear half left. Remember, you need to have the eye full of viscoelastic, so more viscoelastic, very important to keep it under viscoelastic. Now the lens snare introduced again, going around the nucleus, stabilizing it. If you don't, it rotates like that, so it's helpful to get the second instrument and to stabilize it, and then separate the two halves. Now, this is not a new idea. This was first described in 1995, and then later published in 2009 in the Indian Journal of Ophthalmology. This technique was described for decades and used very frequently in certain settings with these dense cataracts. Now I know companies are monetizing this and claiming rights to it, but this is a common technique that's been around for decades. So here's the last bit of the nucleus being sub-chopped with that chopper, and you can see the dense brunescent nature of this lens. Important to use phaco power modulation to minimize our total ultrasonic energy placed in the eye. And of course, using a good dispersive viscoelastic is important to protect that corneal endothelium. So here's just about the end of it. Cases like this often have very little or no cortex left after this dense nucleus has been removed. So great technique here by Dr. Unisov. Beautiful job. Time now for the end of the case. Here's the cortex removal, what little is left there. And then the capsular bag will be filled with viscoelastic. And then the IOL can be implanted. It's important for you as a surgeon to experience all different techniques. So I certainly encourage you to try this in one of your patients. Get some hands-on experience. Try all the techniques that you see here on cataractcoach.com.
All right, so that was a great video on the MyLoop. Let's move on here to devices. We will touch on this one relatively quickly because I believe there's some other good lectures. So we're not going to take a big deep dive here. My experience is somewhat limited in just a few premium lenses in terms of some specialty ones to think about. I mainly use the Alcon platform and have some pretty decent results with the PanOptix and Restore and recently the Vivity. I tried some EDOF lenses, the Symphony. And I think I was a little underwhelmed with that. But the one I actually did want to touch on was this light adjustable lens because of the idea here of novel trends and techniques. I think this one, which has actually been around for a long time, it was project started in 1997 at UCSF. This has been around a while, but is starting to gain a little bit more traction here as the studies and data come out showing that this actually gives a pretty impressive result. So this lens, for those that don't know, it has a photosensitive macromers embedded in the lens silicone matrix. And so with UV light, 365 nanometers, these macromers attach to one another, they form polymers, which in turn changes the curvature of the lens. So after implantation, the surgeon can treat the lens and refine both the sphere and cylinder 2 to 3 weeks post-operatively. So once you're satisfied overall, you can treat the lens once more and lock in the power. And this was FDA approved in November 2017 in the US. So patient selection, I think, is important here. It's indicated for standard phaco with patients with greater than or equal to 0.75 diopters of corneal astigmatism and no macular disease. The pupil has to dilate to 7 millimeters because the optic is 6 millimeters. So to be able to treat it, it has to be, they recommend 7 millimeters. And of course, your patient has to be able to sit still at the slit lamp and hold on to and hold still for these light treatments as well. So the advantages here, I think, are relatively obvious. The studies are showing that the likelihood of getting uncorrected 20/20 vision is staggeringly high. There's an FDA study with 600 patients, and I think you're twice as likely to get that uncorrected 20/20 vision with this lens. So you can treat a miss of 2 diopters of sphere and 3 diopters of cyl. So basically, very likely to get 20/20 uncorrected distance vision, but that's the key, is that it's distance. It's not your multifocal or EDOF, which is kind of the golden ticket these days. So that, I would say, would be one of the big downfalls, that it's just a monofocal. And expectations these days really are trending towards that multifocal, as you know. Other ones, cost of the patient, logistics of multiple visits, potential for corneal astigmatism changing over the years, and then having to wear UV protection goggles. So it's worth looking at this one and reading up on some more. It's a pretty interesting lens. So let's move on here and let's take a look at some other lenses. This is kind of just for fun here. So we have the Fluid Vision accommodating IOL, which moves fluid in and out of the lens itself in response to tension on the lens itself. There's some interesting preliminary data here. You can see on the top there, the SBL segmented bifocal, which is asymmetric segmented bifocal, and a 3 diopter sector shaped ad at the bottom. Still waiting on trial results here, but interesting, not available in the US, of course. And then the Lumina by Aqualens at the bottom, and made from 2 shifting optic elements. You put this in the ciliary sulcus. I think up to 4 diopters of accommodation. Pretty interesting. Some small studies showing proof of concept. And I think this actually might be available in Europe soon. So another one to think about. So the last of our devices here, we'll take a look at. This is not super exciting, but some of the Alcon Intrepid line. So the phaco handpieces, they do have some upgrades here that I think are just, again, worth touching on, looking at. This hybrid tip, which you can see in the picture there. It's shaped slightly differently to make more efficient stroke, reduce clogging, better cutting efficiency. It's not for the most dense cataracts, but it's interesting. And then there's a balance tip that they have, which is supposed to have enhanced torsional movement, reduced tip movement at the incision, and reduced clogging as well. And then also the IA transformer handpiece, I think, is interesting. You can transition from coaxial to bimanual to allow you to get greater access to difficult subincisional cortex. I think these are just, again, interesting little tidbits here to take a look at to help you with your optimizing your surgeries. The very last topic here, this one's interesting. So I think perhaps some of our most dreaded complications, a dropped lens, dislocated late intraocular lens. Previously, the struggle with and the miseries of an anterior chamber intraocular lens are really the only option. But now, of course, we have these options of posterior fixated lenses. So this would be our iris fixated lens, scleral sutured IOL, or the sutureless scleral fixated IOL, like the glued or the Yamane or the Theranos 3-port, which I have a video of here. So if you can perfect this or find a colleague that has good experience with it, I think it's an amazing alternative and a technique that seems to have really been refined pretty nicely in the last few years here. So the issues with these, as you can imagine, it's a more difficult surgery. There's more holes in the eye, greater surgical time, and the complications that you do have are bigger. Lens tilt, vitreous hemorrhage, detached retina. So again, I think it depends on the patient. If you have someone 75 with a good cornea and good AC depth, maybe the ACIOL is still your best option. But otherwise, thinking about a posterior fixated lens, I think is a big trend here to look into. So our last video and our last slide here is actually that of one of my partners who has a posterior fixated lens here. This is the Theranos 3-port. So we'll take a look at that briefly next, and that'll be our last video and last slide. So let's take a peek at this here. So the lens that he's going to be inserting is just a standard 3-piece. I think it might just be an MA60 MA perhaps, but we'll see. He does this pretty skillfully and pretty quickly. You'll see him go through the ports to do this handoff technique to grab the haptic, and then we'll see him cauterize the tip of it to allow it to be fixated, and then we'll see him get the other haptic and just see how easy he makes this look. See him grab that second haptic there and get that lens placed just so beautifully and so well centered there. It's really nicely well done there. Looks great. He does lots of these, so it makes it look easy. All right, that's it. I appreciate you guys coming. I hope that was helpful, and we'll have a short Q&A to follow here, but I appreciate you guys paying attention and joining me for this one. Have a good day, guys.
Well, those are some great cases. I tell you, I can never get tired of watching that type of surgery. Thanks to Dr. Sacher for just a great presentation. And that really wraps up the ophthalmology track here at Eyes on 2022. One of the best virtual meetings I've certainly ever attended. And my hat is off to the entire Covalent team for putting this all together. I know how much effort went into this. We want to thank all of you for joining us. I hope you found the process entertaining, but more importantly, I hope you found it educational. At this point, I'd like to invite all of you to join us at the exhibit hall. Exactly, we're going to the exhibit hall right now. We'll close up the meeting and hear some closing remarks from the team here at Covalent and Eyes on 22. So join me in the exhibit hall, and I will see you in a few minutes.